Hi, good afternoon. I'm actually here with my colleague, Dr. Karen Lee from the Department of Health, New York City Department of Health, and we'll be working together, and hopefully we can work together on some of the Q&A as well. First of all, I should say I bring you welcome from Mayor Bloomberg. We hope you're all, those of you from out of town, we hope you're enjoying the city. We'd like you to spend as much money as possible. We need the sales tax, you know, it's just the way it is. You may find it difficult buying a sugary drink more than 16 ounces in size. That's part of the Mayor's Obesity Task Force. But I guess in deference to the fact that Coca-Cola is one of our sponsors, I should point out you can buy two 16-ounce if you really want to and just drink them. You can also get Coke Zero, which is a very good drink. So, how do I make this start? Just the... Oh, it is on full screen. Okay, terrific. Okay, that's fine. So this is a sort of slightly unusual partnership in my experience anyway. I'm an architect. Dr. Lee's a medical doctor and epidemiologist. And it's slightly unusual for us to work together, partly because, well, let me ask this question. How many architects and city planners are there in the room? Just raise your hands. One. Thank you. Thank you. But that's my point, only one. And, you know, I think for the most part, architects and planners would say, well, you know, obesity and its associated health issues, it's a medical problem. It's not really about design and planning. And what we've been trying to convince people, of course, is that the built environment is a factor. It contributes to our sedentary lifestyle. And you can be, as an architect or a planner, part of the problem, or you can be part of the solution. And we have found ways that we can help architects and planners achieve that goal. So some of this, of course, as most of you are medical professionals and epidemiologists, this will be not new information. But there is a long track record of the relationship between urban design and health. And back in the 19th century, of course, it was very much about infectious disease, those chronic diseases like tuberculosis, cholera, typhoid, and so on. And of course, now we've managed to overcome most of those, and we're in an era, really, of chronic disease, of which obesity and its related health problems are the major factor. And then you think about the relationship between urban design and disease back in the old days. A lot of the solutions were based on planning and urban design, reducing overcrowding, improved sanitation, better water quality. All of these things helped to reduce some of those major epidemics, reduce waterborne disease, and so on. A strong relationship then between planning, design, and public health. And these are just a few of the examples. In New York City, the water system was established in the mid-19th century. Central Park bringing ventilation, bringing recreational opportunities to people. The creation of sanitation department. Zoning changes like Tenement House Act, which banned the construction of housing that didn't have light and air. Transportation in terms of subways, and the zoning ordinance that brought light and air into the street system. And of course, the results, as we know, infectious disease dropped dramatically between the 19th century and the 20th century. Now, by 2011, down to 9% death rates from infectious disease. And even after, or even rather before the introduction and the wide use of antibiotics. So today we're really talking about chronic disease. As you all know, I don't need to tell you this, that after tobacco, obesity, high blood pressure, and so on are really the top 5 causes of death in the United States. And, you know, this, I often talk to some of my architect and planning colleagues in the United Kingdom, and they think it's all just about fat Americans, you know. So I show this slide just to show them that it's really not. It's really a global problem, as all of you here already know. So I think what we argue is that obesity and diabetes have increased rapidly, and I think as people were saying today, it's not necessarily genetic, but our built environment has certainly changed. The way we drive everywhere, the way we don't walk, the way we have access to unhealthy food more easily and cheaply than healthy food, And just our behavior, if you look at that slide in the bottom right, here we are riding the escalator to the fitness center and ignoring the staircase. So there is a growing evidence-based design. Architects, generally speaking, have not felt it necessary to have any scientific basis for what they do. They just figure they're right. So it's quite reassuring to know that there is, in fact, a growing body of evidence that shows that there are certain built environment things that you can do that, in fact, lead an established relationship between improving mobility. Things like increasing stair use, point-of-decision stair prompts, improving, you know, the staircase used to be, before the invention of the elevator, used to be one of the most wonderful things in a building. You know, it was three-dimensional space. It was the one place where there was sculpture. With the invention of the elevator, they got shunted to the back of the building in the dark, often without windows. Everybody rode the elevator. What we're trying to do is to demonstrate to architects that that opportunity needs to be brought back, that people will use staircases if they're attractive, if they have light, if they have even music and art, and it's an effective way to encourage mobility. And it's also actually efficient in buildings to allow staircase access between floors rather than just by elevator. Access to recreation, obviously, and walking, bicycling, and transit-oriented development also increase physical activity, and it's been demonstrated that these things are effective in improving mobility. Increased access to healthy food and beverages. We have a FRESH program that's we're working with, which improves access to healthy foods in areas where those are currently not available, and trying to decrease exposure to unhealthy food, hence the bans on trans fats, the limitation on access to sugary drinks, and also trying to improve. I think somebody was talking earlier today about educating people. It's not just about allowing access or providing access to healthy choices, but educating people in making those healthy choices. Do you want to talk a little bit about this one?
Sure.
Okay, go ahead.
So this is a little bit about the process of how we started doing this work in New York City. In 2006, I came to New York City's health department from CDC, where I was actually supervised by Michael Pratt, doing this kind of work. And so we began this work really with a conference launching this work. And you know, the lessons learned that I'm going to share with you here will be actually illustrated, I think, as the rest of the presentation goes on. So some of the key lessons learned around doing work in the built environment include, clearly, those of us in health do not actually build or design our built environments. Our buildings, streets, and neighborhoods and their amenities are actually designed and built by planners and architects and developers. And so it was really key that we needed to form partnerships with these groups. The other is, of course, as we started working with these different groups, they identified to us that not only were health benefits, potential benefits that could occur from the interventions that we were talking about, but also additional benefits in sustainability and the environments, in economic development, and that it was really important to actually highlight these benefits for sectors outside of health as we develop these partnerships. The third is that there were really important complementary roles that would be played between health and those who are outside of health. So some examples are this. So in health, when we began this work, we saw it as our task to really present the research-based evidence, to present what we knew about the epidemiology of disease and risk factors within the city of New York. And we organized early conversations, early conferences and meetings with other sectors in order to share this information. But then we really relied on the other sectors, sectors like Commissioner Burney's Design and Construction Department, Transportation, City Planning, Buildings, Parks, to give us ideas of what they thought was feasible in the local context, and to also identify for us key opportunities and synergies that we could align with quickly and immediately in this environment. Health then played actually an important role in supporting the implementation of the ideas that were generated. So we were able to take the ideas that were created to create intersectoral initiatives for which we actually staffed coordinators to help the process to move along. So we assisted with strategy and planning. We also assisted with evaluation of initiatives as they were undertaken. Design and construction, transportation city planning as our core partners in this work has also played really key co-leadership roles with us in moving all of this forward. And then we've also partnered with researchers, academics, who helped us with evidence synthesis and reviews, and also are currently helping us on evaluation research. So we'll illustrate now some of the strategies that we talk about. One of them is the Fit City Conference. The Fit City Conference was the very first conference that we had in June of 2006 when I came here to launch this work. We actually had the first Fit City be a brainstorming conference where health presented the evidence, the epidemiology, and we asked the design and development and planning communities for their ideas of what could be done in public policy and in private practice to actually shape our buildings, streets, and neighborhoods to make them healthier. And we've then, initially when we started, we didn't know we were going to have so many conferences, but this has become actually an annual event where we actually celebrate the successes together of what we've been able to accomplish in the previous year, and we use them to actually strategically move forward the next steps over the next year. At Fit City 7, I'm happy to say we were able to have on the commissioners panel 9 city agencies participating. And at Fit City 2, essentially, the active design guidelines were born. And I think Commissioner Burney will come back and talk about that now.
So these Fit City conferences, they were obviously heavily dominated by design folks, architects, planners, and so on. And, but we also partnered with academics, Craig Zimmering from Georgia Tech, Craig Nickel, who's now up in Canada, who were doing evidence-based design on these issues. And in 2009, we realized, well, there is enough body of evidence here that we could actually put together these as a guidebook for architects and planners. So they would have real tools so that when they were designing buildings or neighborhoods, they could actually implement these best practices that would lead to better mobility. So in 2010, we published these active design guidelines. You can actually download them from the URL that's at the bottom of the slide there. There are 4 chapters. One the first gives background on environmental design and health, the relationship, the history. Then there's a section on urban design at the city level. There's a section on building design within buildings. And then there's a section on synergies between sustainable design, universal design, which has to do with barrier freedom for people with disabilities. And incidentally, there had been some concern that the measures we were taking to increase mobility might be in conflict with measures that the law requires to allow barrier freedom for people with physical disabilities. But in fact, we found just the opposite, that the more you can eliminate barriers for those with disabilities, the more you limit barriers for everybody, and it does help. It helps mobility. As Karen mentioned, was it really 9 city agencies? It's obviously a record of some sort. But having 9 city agencies is 12. That's just almost impossible, but it happened. Some of the synergies, obviously, between health, safety, environmental sustainability, when you're not using elevators, you're saving energy, universal accessibility, as I mentioned, and some of the economic benefits. And this matrix just talks about the sort of correlation between fuel and electricity use, air quality, as well as obesity, diabetes, and heart disease. We find the more we do this work, there are even more synergies between not only obesity, but obviously senior health, between air quality because of transportation measures, and obviously the reduction in use of fossil fuel. Some of the benefits of creating more accessible places, safer places to walk, to take transit, making elevators more available for those who do actually need them. Some of the infrastructure cost reductions because of the savings, because of reducing sprawl, particularly in transportation-based planning. You do save actual money in terms of infrastructure, in terms of road construction, in terms of water and sewer infrastructure. And of course, people in walkable, transit-rich neighborhoods spend less money on transportation, and that's particularly beneficial to low-income people. And again, I think, as has been pointed out earlier, there's a strong correlation between obesity and its health-related issues and people of low income. Job creation, because many of the co-benefits in terms of infrastructure get some payback in terms of increased jobs. Bike and pedestrian projects actually create more jobs than road infrastructure projects per dollar invested, because they require less land and they tend to be more labor intensive. The Stair Prompt campaign, this is something we've been working on very strongly in New York City, both within the health department and within the city's portfolio of its own buildings. And we found that this has been extremely effective. It's a very simple and cost-effective thing to put a sign on the wall, open up your elevators, open up your staircases, and people do use them. It's been a very effective and simple thing to do. In the built environment, there is a system called LEED, which stands for Leadership in Energy and Environmental Design. And the US Green Building Council credits buildings that accomplish a certain number of characteristics under this program, which has mostly to do with energy consumption and with the use of sustainable materials. But we now have a point in the LEED system for implementing active design. So this has made a tremendous additional incentive for architects and designers to incorporate guidelines, because if they do, it gives them a point toward their accreditation under the LEED system. And there are a number of things that you can do. Increased density gets you points in the system, public transportation access, putting in bicycle storage in changing rooms, improving physical activity will give you an innovation credit under the LEED system. We're also looking at changing our local codes to improve access and mobility, increasing drinking water access, for example. A couple of things you can do to increase mobility in the street and in city parks is to provide benches and to provide water access. It means that people will use them, are more likely to take that walk, particularly if they're seniors, if they know there's water there and there is access to somewhere to sit on the way. Incentivizing stair design. An awful lot of our codes have really mitigated against good stair design because they have not brought value to the building. They've been counted as floor area. So there are ways that we can incentivize, but change the code that would allow developers and architects to build bigger and more attractive stairs that would more likely to be used. Zoning for bicycling, obviously, as you probably know, like many other cities, bicycling has increased exponentially in New York City. The small graph to the right of the screen there, which is probably too small for you can see the sort of exponential increase in cycling because of the bicycle program in New York City. This year, as you may know, we're introducing a bike share program similar to the one in Paris and London, and that has been a very successful component. And then, perhaps last but not least, just in terms of improving the public realm, the city's street design manual, the emphasis now on creating plazas, that balance between the car and the pedestrian has long been dominated in this country by the car. But I think that sort of, America's love affair with the automobile is beginning to wane, partly because of high gas prices and so on. But also the idea that within the city in particular, people do want to walk. They want a walkable city. And immediately we've created a series of plazas in the city in the last couple of years, and they immediately fill with pedestrians. And people are taking to the streets, walking more. And that program that incorporates public art, new street materials, activity on the street, has been a very successful way of getting people out and walking the city. Summer streets, as I think Gretchen mentioned, in the summer now we are closing streets to traffic completely so that in the better weather people can get out there, have street fairs and walk around and just take the cars away for a temporary period. Play streets, again, one of the goals of the Mayor's Plan YC 2030 has been to have access to a public park within 10-minute walk of every resident in the city. and there is a large park program, but where that isn't possible, the Department of Transportation is closing streets, working with communities so that we have play streets accessible in the summer, giving people somewhere for outdoor recreation that they may not have at the moment. And as I mentioned, the Fresh program, obviously the other side of the coin in terms of fighting our sedentary lifestyle is getting access to fresh food, and the city is running our Fresh program, which incentivizes developers to provide access to fresh food in areas that are what we call food deserts, where there's limited access to fresh food, and that's an ongoing program that the city is promoting. And I think, as I mentioned earlier, we have been supported by CDC, mentoring now other cities in the use of the active design guidelines and helping other cities implement some of the best practices that are in the guidelines. So to date, we've actually distributed about 15,000 copies of the design guidelines. We've also been running a training program. We've trained over 3,000 architects and designers in the US in how to implement the guidelines, so we're hoping that that will filter through to urban design in other cities. And we've been mentoring 14 other cities in implementing the guidelines. Commuter cycling has gone up in the city 262%. Bus and subway ridership up 10%. Stair use is increasing all the time. And interestingly enough, there's been a decrease because of the activity on the street in traffic fatalities, in traffic volume, and even a decline in vehicular registration as people are using public transit and walking more. And we have started reversing childhood obesity, right? Not by much, but a little bit. Okay. We're now in the process of setting up a center for active design that we hope will be a focus for this. It's been not an easy task coordinating the work of a dozen city agencies and working with partners like the American Institute of Architects and academics who are distributed all across the country in different parts of the world. So we're hoping that the Center for Active Design, which will be created this summer, will be a center focus where we can coordinate literature, work on training, provide technical assistance, work on policy development, hopefully coordinate some of the research that's been talked about today, and be just a center for knowledge and information. And that concludes. Thank you very much. Okay. All right.